Good day, my dear undergraduate and emerging postgraduate students. Welcome to What Next? You can very well appreciate another enclosure reading Need or Next. The situation is so very fluid that things keep changing moment to moment, day to day. Incidentally, this class encompasses medicine and pathology. And perhaps psychiatry can also be considered to be a part of medicine. And it's meant for all MBBS students and not any one particular year. I hope you are able to appreciate the theme that has been picked up from the net. A wonderful one, where there is a serial disintegration. This is a clinical scenario. A 63-year-old male was found waiting in a railway station. When the authorities tried to help him, he was unable to communicate. Ultimately, he was taken to his residence with great difficulty. The episode recurred at a different venue. He was unable to recall names and did not have orientation of time. Further, his behavior was unpredictable. He was then taken to a neurologist and a CT scan was taken. Your diagnosis is, I hope you people are able to appreciate it. There are some arrows pointing out. Something that you people should be able to appreciate, which we shall be seeing in the coming discussion. So, here again, we shall be dealing with all these subheadings. Think of the subheadings. The subheadings will take you to the list. For each topic, there will be something that is unique and specific that we should always concentrate upon. Let us see what it is in a case of Alzheimer's. Initially, around 2019, the cases were about 45 million. Perhaps before that, we were not having the data. But around 2050, it is predicted that 131 million people might be affected or afflicted with it. 65% of the cases are found to be sporadic, whereas 15% are familial by origin. Other disorders such as Downs can be coexisting or predisposing. There is also a progressive dementia. The main thing in a case of the Alzheimer's will be the amyloid beta plaques. 40 and 42 are the numbers that have been given. Amyloid beta plaques, you shall remember. So these are the things we will be seeing. Now, this is the cerebral cortex, all of us know. One region that is highly specific will be the hippocampus, the amygdala, and the entorhinal cortex. These regions we should be having in mind. It is one of the most common cause for senile dementia. So the asterisk here probably it leads us to a question. It is a neurodegenerative disease. Insidious in onset. We find that there is some kind of a change, but not sharp enough. It affects the higher intellectual function, results in mood disorders, memory loss, and aphasia. As I have been telling you people, one person in about 60 to 64 years Then suddenly, up to 74 years, you find that there is an increase. And up to 84 years, there is a greater increase. And finally, beyond 84 years, the percentage is about 40%. Rarely it can be familial. That is what we had seen earlier. Now look at this picture over here. So this is the normal brain and this is the ventricle over here. I find that the convolutions of the cerebrum are found to be closely opposed. Whereas in this case, the gyri are narrowed and the sulci are widened because of the atrophy of the brain parenchyma. Also, you find that there can be a compensatory distension of the ventricles. Hippocampus also, you find that it is atrophic in this region. Courtesy Allenby. So, this person was a German neurologist, Alois Alzheimer, and he had seen a few cases wherein there was a very remarkable observation. And this patient, August Dieter, you can see the observation or the kind of emptiness in the look. Absolutely lost. She does not know where she is or what she belongs to. Obviously, there will be a lack of communication and orientation. All the features are brought about in this case. If such a picture is given, one such diagnosis will be Alzheimer's. Now, what are the signs and symptoms? For one to diagnose, you find that there are a plethora of signs and symptoms. Inability to communicate, not aware of the recent experiences or the surroundings, weight loss, lack of interest, seizures, general physical decline, groaning, moaning, and lack of the bowel and the bladder control. At one point of time, they become completely dependent on the others. And finally, bedridden. So this is the history of the Alzheimer's. On examination, either radiologically or at autopsy, you find that there is a cerebral atrophy, widening of the sulci, narrowing of the gyri. Frontal, parietal, and temporal lobes are all involved. The enlargement of the ventricle is called as hydrocephalus ex vacuo. Can it be a question? Why not? So you people should be aware that the structures affected are these: hippocampus, entorhinal cortex, and amygdala. The risk factors are from apolipoprotein E. So allele for this is supposed to be one of the risk factors. High BP, head injury, they are all again supposed to be hand in hand and precipitating the condition. This is important in the pathogenesis. Thanks to ResearchGate, there are other references. You find that there is a mutation for the APP, amyloid precursor protein. Normally, there is amyloidogenic proteolysis, and you get that amyloidogenic peptides are being produced and they get aggregated. They form oligomers, and the aggregation continues so that they form plaques. Plaques are flat, slightly elevated lesions. And there is also the tau pathology, which affects the synaptic neurotransmission. Finally, there is a neuronal death. Two things you people should be remembering. One is amyloid plaque. The second one is tau pathology. Neuronal death is a sequence. Now, this again is important. So, this is somewhat normal. There is no pathology. Let us see what happens here. There is a healthy individual, AB tolerant, no immune response, and IgM antibody secretion is not efficient, but it is able to clear the AB without inflammation, and there is no pathology. In another case, in Alzheimer's, you find it can be precipitated by the T or the B cells. There is increased amyloid beta reactivity, and there is an elevated interleukin 21 or the TFH. IgG antibody secretion can be there. Ultimately, you find that there is an accumulation of amyloid beta and increased inflammation. This leads to Alzheimer's disease, neuropathy, and loss of the cognitive function, resulting in a dysfunction. This one, I think we people will be able to remember. Microscopically, what can we see? One will be the neuritic senile plaques. This is a normal picture of a brain. So there is a healthy neuron, and see there is no atrophy as such. Here there is a reduction, the features that you have mentioned. Plaques are formed, which are wide areas of thickening that can be seen on the surface. Another one will be the tangles. There will be a central neuron, diseased neuron, around which these get deposited. Also, there can be a neuronal loss, glial reaction. Glial is nothing but fibrous tissue. So see what is happening over here. So this is a normal neuron and this is a matrix. But in the case of Alzheimer, there can be neurofibrillary tangles. They form within the neurons. Usually they are supposed to be affecting the tubules, and then they also get connected to the exterior and form some kind of a fibrous tissue that encompasses or circles the neurons. There can also be the amyloid plaques that we had been mentioning. So two things we are remembering. This we have already seen. So look at this picture. It is very important. There are certain regions like CA3 region of the cerebrum. And this is the amyloid plaque over here. Then there is a neurofibrillary tangle. So there is a neuron over here getting diseased, and you find that there is some kind of a tau protein that is getting formed within. Finally, you find it projects outside, communicates, and then it encompasses the entire neuron. Thanks to Wikipedia and this particular reference, a magnificent work of theirs. What are the lesions in a case of Alzheimer's? One is neuritic plaques. Simple. Spherical or irregular collection of tortuous dystrophic neuritic materials found in the hippocampus, amygdala, and neocortex. Amyloid core in neuritic plaque, AB light chain. Amyloid diffuse plaques in the cerebral cortex and the basal ganglia. Sometimes this can be demonstrated with the Congo-red stain, one of the stains that is used for demonstration of amyloid. Common in trisomy 21. See where all the down is harassing the patient. Neurofibrillary tangle. It encircles the nucleus, flame shape, and even a picture of it can be given. This can be demonstrated by the Belshevsky silver stain. Tau is axonal microtubule protein that is there. Cerebral amyloid angiopathy around the blood vessels. And there is also something called as spheroid bodies, which are elongated, glassy, eosinophilic in the hippocampus. In fact, the description of amyloid itself will be that it is homogeneous, eosinophilic, acellular, glassy, pale, etc. So these are the structures that you people or the lesions that you will have to remember. You can get this. Definitely, it is one of the important questions. The diagnosis can be clinical. It can be radiological. Pathology at autopsy. Biopsy obviously is not recommended. The treatment, of course, will be cholinesterase inhibitors and therapeutic nanotechnology. So this is supposed to be the mode of treatment. And the main thing that we'll be remembering will be the cholinesterase inhibitor memantine. So it is a sequence. I would like you people to refer to the medicine and the pharmacology text for a better rationale. And so also this. You find that there is a sequence And in cases of adverse, what do you do? Mild, what do you do? And what is the ultimate time to discontinue the therapy? I would advise you people to kindly go to the medicine. Courtesy research kit for this wonderful sequence. Molecular genetics and pathogenesis. We had seen already amyloid precursor protein is a cell surface protein which forms beta and alpha secretase cleaves this. The amyloid is separated and lysed. But when there is going to be a defect in this, it gets precipitated and forms plaques and tangles. See you in what next?